How do you determine who can be a good kidney donor? So first of all, you have to have HLA compatibility, and if people are family members, they're likely to have HLA compatibility. If they're siblings, even more so. You also have to have ABO compatibility, and in addition to that, you have to not have the contraindications for kidney donation, and they're going to be inability to consent, which includes anybody under the age of 18, intellectual disability, or an untreated psychiatric disease. Another contraindication is having diabetes mellitus, hypertension with end organ dysfunction, a BMI greater than 35, and malignancy. When do you start statin therapy? If somebody has established arteriovascular disease, such as acute coronary syndrome, stable angina, or they have a history of arterial revascularization or stroke, TIA, or PAD, then you're going to start them on statin. That's secondary prevention. For primary prevention, you are going to start a statin if the person has an LDL greater than or equal to 190 milligrams per deciliter. You're going to start high intensity. If somebody has age greater than 40 and they have diabetes, you start high intensity statin if their 10-year ASCVD risk is greater than 20. If it's less than 20, you can start them on moderate statin therapy. If somebody doesn't have any of these things, they don't have the LDL, they don't have age greater than 40 with diabetes, but they have an estimated 10-year ASCVD risk of greater than 7.5 to 10%, then you're going to start moderate to high intensity statins. High intensity statins include atorvastatin 40 to 80 milligrams, rosuvastatin 20 to 40. Moderate intensity includes atorvastatin at 10 to 20, or rosuvastatin at 5 to 10, or simvastatin at 20 to 40, pravastatin 40 to 80, or lovastatin 40. So essentially, high intensity is atorvastatin 40 to 80, rosuvastatin is 20 to 40. Everything else is lower than that. If you're doing a study on a large population and you're looking at several variables, let's say about 3 variables, and you're tracing, a good example that we have over here is cigarette sales, incidence of coronary heart disease over time, over a period of 30 years. And when you look at this data, this is an ecological, also known as a correlational study. You cannot apply any kind of individual level information based on this study. So you can't come to any conclusion such as individuals in this population have an increased risk of blah, 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 if blah, blah, blah. You can't come to any of that conclusion. That is known as an ecologic fallacy. The treatment for acute DVT or PE is going to be an oral factor 10A inhibitor such as rivaroxaban. You treat for greater than or equal to 3 months. Let's say you had a patient with an acute DVT that was on menopausal hormonal therapy. Well, that therapy has estrogen, and estrogen is known to increase the risk of DVT. So if they had the DVT, you have to discontinue this menopausal hormonal therapy. If the patient says that they have symptoms that they're not willing to tolerate without the hormonal therapy, one of the symptoms in particular are hot flashes. Okay, you can use a selective serotonin reuptake inhibitor such as escitalopram or a serotonin norepinephrine reuptake inhibitor such as venlafaxine, which can improve hot flashes in about 50 to 70% of women. So this is an alternative therapy. Let's say you have a patient who comes in with the following signs. They have a loud P2. Okay, so the pulmonary valve is shutting very hard. Okay, so there may be something going on there. Right-sided S3 or S4, a holosystolic murmur of tricuspid regurgitation, a precordial heave, JVD, ascites, peripheral edema, hepatomegaly. One or anything or a combination of these things. These are all signs of right ventricular failure, okay? Or we should say that there's definitely a buildup of pressure in the right side of the heart, and it's backing up into the venous system. And this is where we see the JVD, the ascites, the hepatomegaly, so on and so forth. The tricuspid regurgitation could be from increase in volume size of that right ventricle that's not allowing the tricuspid valves to close properly. So these are all signs of pulmonary hypertension, okay? Now, pulmonary hypertension is going to be classified into 5 different groups, right? Well, what I should say is that pulmonary hypertension is one etiology that can cause these signs and symptoms that we saw of right-sided overload, okay? So let's look at these things. Pulmonary hypertension can be classified into 5 different groups, and we want to classify it into these 5 different groups because they have 5 different etiologies and 5 different treatment modalities. So the first one is group 1, and this is just plain old pulmonary arterial hypertension, like actual hypertension in the pulmonary arterial system of the lungs. Next one is group 2, and this is when it's due to left-sided heart disease. Okay, so there's backup in the left side of the heart that is now transmitting itself through the pulmonary circulation and into the right side of the heart. Okay, you can rule this out by doing a pulmonary capillary wedge pressure, which is going to tell you the amount of pressure that is in the left atrium. If that's elevated, then that tells us that it may be due to left heart disease. Next one is group 3. So this is due to actual lung disease of the interstitium of the lung. So this is chronic lung disease or hypoxemia, which can be due to obstructive sleep apnea. Okay, so for this, you want to do a workup for lung disease or a what do we call that? The sleep study. What's the fancy name for the sleep study? I got it over here somewhere. Polysomnography. All right, so you could do a polysomnography to rule out obstructive sleep apnea. Next, we have group 4. Group 4 is going to be pulmonary hypertension due to chronic thromboembolic disease. Okay, so chronic thromboembolic disease. Next, we have group 5, which is other causes, and sarcoidosis is in that group. Okay, so a granulomatous disease that is affecting the lung tissue also. Okay, this can lead to pulmonary hypertension. So we have the 5 different groups. First one is pure pulmonary arterial hypertension. Second one is due to left heart disease. Third one is chronic lung disease or hypoxemia. Fourth one is thromboembolic disease, chronic thromboembolic disease. And fifth one is sarcoidosis. Okay, so what if you have a patient that comes in with these symptoms? The first thing that you want to do is an echocardiography. Okay, you want to look at the function of the heart, all right, and see if there is actually an increase in pressure in the pulmonary artery, and if there is marginal right ventricular function. Okay, this marginal right ventricular function can render patients susceptible to vagal bradycardia and hypotension. Okay, so if they're doing a Valsalva maneuver, they can just pass out after doing that. Okay, exertional fatigue and syncope. They can also get right-sided ischemia. Okay, the right ventricle is perfused during systole and diastole. So if there's a low stroke volume coming from the heart, this can affect the right ventricle. The right ventricle is more susceptible to that low stroke volume than the left ventricle is because the left ventricle is perfused during diastole. All right. So they may have some episodes of angina. And then the venous congestion that we talked about earlier. So first part of your initial evaluation is a transthoracic echo. And then after that, you're going to work it up to see what is the cause of it. If the person has pulmonary hypertension due to left-sided heart failure, then you're going to treat that the way you do it, right? Renin-angiotensin inhibitor and a cardioselective beta blocker. If they have something due to chronic lung disease or hypoxemia, that's group 3, you're going to address the underlying disorder there, Okay. If they have chronic pulmonary thromboembolic disease, that and you can diagnose this by using a ventilation perfusion scan. If that comes out positive, then you can treat that using a pulmonary thromboendarterectomy surgery, right? Big surgery. Pull out the clots from the pulmonary vascular tree, and they have to go on lifelong anticoagulation. But let's say they have group 1, okay? Plain old pulmonary arterial hypertension. Now, there could be a lot of different things that are contributing to this increase in pulmonary artery pressure, okay? Such as connective tissue diseases, such as scleroderma, okay? So if we think that this is the case, then we need to do a further investigation, okay? Other things that can cause pulmonary arterial hypertension are drugs and toxins such as amphetamines, okay? If there is no reasonable cause that we can find for this group 1 pulmonary arterial hypertension, then we call it idiopathic pulmonary arterial hypertension. And there is a treatment that we can use for this. You can use a pulmonary vasodilator, right? Pulmonary vasodilator. And what you're going to use is a phosphodiesterase type 5 inhibitor known as tadalafil. Okay, this is going to increase nitric oxide and relax the pulmonary circulation. In addition to that, this is dual therapy. Okay, so you're going to use the tadalafil, and you're also going to use an endothelin receptor antagonist. An example of that is bosentan. All right, this blocks endothelin. Endothelin is a vasoconstrictor of the pulmonary tree that is produced in the lung. Okay, so you're going to relax the pulmonary vasculature with 2 different approaches, 2 different mechanisms. Number 1 is the phosphodiesterase type 5 inhibitor, and the second one is the endothelin receptor antagonist. The combo of these 2 drugs has been shown to delay the progression of the disease and reduce the number of hospitalizations for right-sided heart failure. Just a quick review of the clinical features of early congenital syphilis. So perinatal, there can be intrauterine fetal demise, prematurity, low birth weight, focal necrosis of the umbilical cord. What you're going to see once the baby is born, mucocutaneous symptoms such as snuffles, which is copious rhinorrhea, which can be purulent or serosanguinous. You're also going to see a desquamating maculopapular rash on the palms and soles. You may see fissures near orifices such as the anal orifice and the oral orifice. You will also see jaundice. In terms of musculoskeletal anomalies, you will see long bone abnormalities such as periosteal thickening and metaphyseal erosion. In terms of reticuloendothelial symptoms, you may have hepatomegaly and splenomegaly, lymphadenopathy, anemia, thrombocytopenia, leukopenia, and leukocytosis. Okay, they may also be born with a fever, and it's usually in a mother who has had limited access to prenatal care. Let's talk about hazard ratio. The hazard ratio is the likelihood of an event occurring in a treatment group relative to the control group. Okay? So a hazard ratio less than 1 is a good thing. This means that the event is less likely to occur in the treatment group than the control group. So whatever treatment you're doing is working well. If you have a hazard ratio greater than 1, this tells us that the event is more likely to occur in the treatment group than in the control group. So we have to revisit that treatment. If you have an elderly patient that is presenting with signs of dementia, the first thing you want to do, the initial workup, is getting a cognitive testing done. So you can do an MMSE, you could do a Montreal Cognitive Assessment or a mini-cog. These things will give you a baseline cognitive test so you can objectively measure where the cognition is at, right? Once you do that, you want to rule out reversible causes for dementia. Now, reversible causes for dementia occur in about less than 1% of cases. Nonetheless, it's an easy fix. Okay, so you want to rule these things out first. And the workup is going to include a complete blood count, a complete metabolic panel, a TSH, and vitamin B12. Okay. If there is suspicion for other things going on, such as folate deficiency, let's say the person has a drug on board like methotrexate, right? Then we could do folate testing. Let's say they have risky sexual history or some other kinds of signs. We can do syphilis antibodies. We can also do vitamin D, and we can also do a cerebral spinal fluid analysis. This is in select cases where we have suspicion for one of these causes. Okay. Most clinicians also order an MRI as part of their workup, so that's up to you. If you suspect Wernicke-Korsakoff syndrome due to thiamine deficiency, don't get the thiamine level. Just give them thiamine. You're not going to hurt them from giving them thiamine, okay? Unless they're acutely alcoholic or something like that, and then you have to give them dextrose first. But if you're suspecting a primary thiamine deficiency, then you're not going to test for the thiamine. You're just going to give it. Once you do all those things and you rule out any reversible causes, then we can go ahead and say, all right, this is your typical dementia and you're going to treat it as such. And just briefly correct myself. You always give thiamine before you give glucose. Thiamine before glucose. So let's say you have your typical dementia-related cognitive impairment, not due to any of those reversible causes that we mentioned. What is your first line treatment? Your first line treatment is going to be symptomatic treatment, which is use of acetylcholinesterase inhibitors, such as donepezil, rivastigmine, or galantamine. There is also an NMDA receptor antagonist that you can use, known as memantine. Keep in mind that these things are symptomatic treatment. They're not going to necessarily change the course or progression of the disease, aka they are not disease-modifying medications. Let's say you have a person who has an occupation which exposes them to heavy sunlight, and they come in with a rash on this area of their body that is exposed to such heavy sunlight. Usually it's going to be the face, the scalp, the ears, upper chest, or dorsal hands or forearms. And you look at the lesions that they have, and it is small, rough, erythematous, keratotic papules that is usually easier to feel than they are to see. This is the description for actinic keratosis. There may be other signs of chronic photo damage, such as dyspigmentation, wrinkling, thinning, and telangiectasia on the skin. Now, don't just let this fly right by you. There is a 20% risk of progression to squamous cell carcinoma in untreated cases of actinic keratosis, so you want to treat this. If it is an individual lesion that you see, you can use cryosurgery or surgical excision to remove the individual lesion. However, there are times where there are many small lesions present. So in this instance, the treatment of choice will be field therapy, where you apply a topical cream to the entire region of the body that is affected. The topical cream that you are going to use is 5-fluorouracil. 5-fluorouracil for a period of 3 to 6 weeks. Other options include imiquimod cream, diclofenac, and photodynamic therapy. You have a patient that comes in with community-acquired pneumonia, and you have to decide whether you're going to admit them and how you're going to treat them. So to determine whether you're going to admit them or not, you're going to use the CURB 65 score. And the CURB 65 is dependent on 5 metrics: confusion, BUN of greater than 19 milligrams per deciliter, a respiratory rate greater than 30, systolic blood pressure less than 90 or diastolic less than 60, and age greater than 65. So essentially, mental changes, tachypnea, hypotension, uremia, or old age greater than 65. Each one of these things is going to have 1 point. If you get 2 points, then you have to consider inpatient versus observation. If it's 3 or greater, definitely admit and start considering for ICU, especially if you get to score 4 or 5. Now, how are you going to treat this? It's community-acquired pneumonia. So you're going to treat this with a cephalosporin, or I should say beta-lactam, right? You're going to treat this with a beta-lactam plus a macrolide. First, we need to distinguish what we decide to do with this person. If they're going to be an outpatient treatment, right, then you're going to stratify them into either lower risk or a higher risk. Lower risk is going to be amoxicillin or doxycycline or macrolide. Higher risk is going to be determined if they have an age greater than 65, comorbidities, or recent antibiotic use. If they're higher risk, you're going to treat them with a respiratory fluoroquinolone such as levofloxacin, moxifloxacin, or gemifloxacin, or beta-lactam plus macrolide. Beta-lactam plus macrolide all day is pretty much the main thing that you're always going to use, whether they're outpatient, inpatient, or ICU. If they're inpatient, you're going to do beta-lactam and a macrolide IV. Okay, so example of that is going to be ceftriaxone, azithromycin. Is azithromycin available IV? Yes, it is. Zithromax. All right. So you're going to do beta-lactam and macrolide IV if you have them inpatient, or a respiratory fluoroquinolone IV. That's still the case. Okay. So really the only thing that's different here is if you have a lower risk patient and you're going to treat them outpatient. It's going to be amoxicillin, high dose, 1 gram TID, or doxycycline, or a macrolide. Okay. That's the only treatment that's going to be different. If you put them in the ICU, still beta-lactam and macrolide IV, or beta-lactam plus respiratory fluoroquinolone. Okay. If it's hospital-acquired pneumonia, vancomycin plus ceftriaxone. If it's community-acquired pneumonia, ceftriaxone plus azithromycin. Hospice care is specifically for people that have a life-limiting illness, which is defined as a prognosis of less than or equal to 6 months, and have chosen to cease disease-modifying or curative therapies. The patient may change their mind while they're in hospice and say, hey, you know what? I want to pursue this experimental treatment for XYZ. They can do that. They can leave at any time, and they can also return back to hospice at any time. And remember that when it comes to discussing the pros and cons of any particular kind of treatment or intervention, leave it up to the specialist that does that intervention to discuss the risks and benefits. If that's not your purview, you stay out of it. If a patient wants to enter hospice care but they can't give their own proper consent, you can use the consent of a surrogate, close family members. There are no contraindications to hospice care. You just have to meet the indications that I mentioned earlier: prognosis of less than or equal to 6 months, and the choice to cease disease-modifying or potentially curative therapies. Oral thrush is common in people taking inhaled corticosteroids. The first-line treatment is going to be a nystatin suspension or a clotrimazole troche. If that doesn't work, then you could give an oral fluconazole. Diabetics can develop diabetic kidney disease, which will result in damage to the kidney. Now, the earliest thing that happens in diabetic kidney disease is glomerular hyperfiltration. So there's going to be an increase in glomerular hydrostatic pressure. And this is mediated by a dilation in the afferent arteriole and a constriction in the efferent arteriole. This is a natural consequence of their own physiology. This is going to increase their GFR, and what you're going to see is a decreased serum creatinine and an increased urine albumin to creatinine ratio. Okay? Now, when you see this, you can do something to prevent or slow down the progression of the diabetic kidney disease. What is the thing that you're going to do? You're going to decrease the glomerular hydrostatic pressure. How are you going to do that? Remember, there's this hormone, angiotensin II, that causes vasoconstriction at the efferent arteriole. So you're going to give an ACE inhibitor or an ARB to block angiotensin II. Dilate the efferent arteriole, and in that situation, decrease the glomerular hydrostatic pressure. You have a pediatric patient that sustains head trauma. The question is, are you concerned about intracranial injury? We're going to separate these pediatric patients into two age groups. You're going to have the babies, less than 2 years old. You're going to have everything else above the age of 2, right? From 2 to 18. In both of these age groups, there's going to be high-risk features. And any one of these high-risk features are going to be risks for intracranial injury. So then we'll have to do a CT scan of the head without contrast to further investigate. Let's look at the differences between the two age groups. Well, first, let's look at the commonalities. In both age groups, if there's altered mental status, we're suspicious for intracranial injury. Do a CT scan. The way altered mental status is going to present in a child less than 2 years old is not going to be the same as an adolescent, for example. An adolescent may have somnolence and agitation, whereas a baby less than 2 years old may just have fussy behavior. The parents will know. The next commonality, common high-risk features in both age groups, is loss of consciousness. The next one is severe mechanism of injury. Now, how do you define severe mechanism of injury? This is going to be different in the two age groups. In babies less than 2 years old, we're going to define severe mechanism of injury as a fall greater than 3 feet, high impact, or a motor vehicle collision. In the age range greater than 2, the fall height is greater. It's not 3 feet, now it's 5 feet. Nonetheless, we still have high impact and motor vehicle collision as a severe mechanism of injury. The next features are going to be different for both age groups. For the 2 to 18 age group, the high-risk features that we have in addition to the ones we've mentioned are vomiting and severe headache, or signs of a basilar skull fracture such as CSF rhinorrhea. CT scan without contrast of the head. High-risk features in the less than 2 year age group that are different from the other group are a palpable skull fracture. No shit. In addition to that, another one is a non-frontal scalp hematoma. Non-frontal scalp hematoma. The areas of the scalp, if you have a hematoma, that have the highest risk are going to be the parietal area and the temporal area. If you have a hematoma that is greater than 3 centimeters on any part of the scalp that is not the frontal part of the scalp, this may indicate an underlying skull fracture or an intracranial injury. CT head without contrast. let's say you have somebody who doesn't really meet the full criteria for high risk features, but they're close. They're close. Let's say the hematoma is 1 centimeter large on the parietal, right? Instead of 3. Or the fall height was 2.5 feet instead of 3. This is intermediate risk. Observe them in the emergency department for 4 to 6 hours.